Are you happy to take questions afterwards?
So that's what I was going to say. I'll talk for a little while, but probably the most interesting bit's always the question and answers. So very happy to take as many questions as you want to throw at me. But I was asked to talk a little bit about new treatments. So I'm going to talk about a few recent clinical trial results. Some of them you might already have heard a little bit about because some of them have hit the news, but maybe I can answer some questions about them and we can discuss them a bit. So I'm going to talk about the recent results of clinical trials covering inflammation, infection, and mucus in bronchiectasis. But of course, most people with NTM also have bronchiectasis. So this will hopefully be very relevant to you. Before we begin, I always say, bear in mind that I do a lot of research studies with pharmaceutical companies in the field of bronchiectasis. All the funding goes to my university for these things, but I am involved in these trials, so take into account that I've got a conflict of interest. And I don't give medical advice for individual patients on these calls. I speak in general terms. So if you hear me say something about a new treatment, always discuss it with your doctor. So this is sort of where we are at the moment in terms of treatments for people with bronchiectasis. We give a lot of inhalers, nebulizers. Patients take inhaled steroid, bronchodilators, antibiotics. But we need a lot more treatments for people with bronchiectasis. And so the request is, please, sir, can we have some more and some better treatments for people with bronchiectasis? Obviously, for NTM, what we would like is better antibiotic treatments that might be able to clear the infection more effectively or allow us to give shorter courses of antibiotic treatment, because for most NTM patients, we're talking about 18 to 24 months of antibiotics as a minimum. There are new antibiotic treatments coming for NTM, and that's exciting. But for bronchiectasis, we also have to think about trying to target the other important components of the disease. So infections like Pseudomonas, inflammation in the lungs, which I think is a really important part of why people have symptoms, the mucus that people produce every day, and lung function that lets you do your daily activities, walk around and enjoy life. And so we need treatments that target all of these things. And the good news is that there is important developments in all of these areas, both for bronchiectasis and for NTM. And it's a really exciting time because historically, bronchiectasis has been a very neglected disease. It was a condition back in the, let's see if I can get my wee pointer on here. There we go. It was first described in 1819, and until the 1950s, nobody had ever really done any research into it at all. There was a small antibiotic trial in the 1950s, and then nothing for 50 years until the early 2000s, when people started to notice that bronchiectasis was getting more common. And since then, there's been an increase in research with the setting up of national registries like EMBARC that I do a lot of work with, and an increase in the number of clinical trials. And clinical trials are really important because as a doctor with a difficult disease like bronchiectasis, I need to know what's going to work and what's not going to work. And the only way to prove whether something works or not is to do a study. And for those, I think most of you will be familiar with how research is done, but usually when we do a clinical trial, what we do is we invite patients like you to participate. You read some information about the study and decide if you think it's something that you might want to participate in. And if you agree to participate, a computer randomly assigns people to one group or another. And the groups are usually a new drug or a new treatment, or the control group, which might be a placebo or no treatment. And the things that we measure are usually the things that are most important to patients, like exacerbations, so chest infections, worsening of the condition, symptoms using questionnaires and quality of life, lung function, and hospital visits. And so it would be lovely if we could find treatments that would reduce all of these things, reducing exacerbations, which are very important, and improve patient symptoms. So I'm going to talk through some of the latest trials that have, all of the stuff I'm going to show you has been published in the last year. And that in itself is quite an exciting thing, in that usually if I was to give this talk, you'd have nothing new to talk about, but 2024 and 2025 have been really exciting years with lots of new things for bronchiectasis. So the first thing I'm going to talk about is mucus, because that's the main symptom that a lot of our patients have, is cough and bringing up phlegm. The reason you bring up too much phlegm, or the reason patients bring up too much phlegm, is that the glands in the airway get bigger and you get more of them. So this is a normal, at the top you can see a normal airway. This is the lining of your lung with the cells. And you have this little mucus gland here that spits out mucus. And even healthy people have a little bit of mucus to keep the airway healthy. When you've got bronchiectasis, you have too many of these glands, and the glands get bigger, so they make more mucus. And that's why you can constantly cough things up. And you also get some inflammation with inflammatory cells, which is what these are. And that also contributes to the mucus. And so if you think about that, you've got this layer of mucus over the top that's thick and there's too much of it. We want to get that out, and we'd quite like it to be a bit thinner and easier for the lungs to clear. And so most of the treatments that we give are aimed at reducing the amount of mucus or making it thinner and easier to get out of the lungs. The first new drug I'm going to talk to you about is called Arena-1. It's an inhaled medicine that is a combination of ascorbic acid, which some of you will recognize as vitamin C, and glutathione, which is an anti-inflammatory type medication. And the combination of this seems to thin down mucus, as shown here. This is a graph where this is the change in the movement of beads of across airway cells, meaning clearance of mucus. And it gets better when you give this medication in 44 patients. So the trial that was done with this medication was a phase 2 trial. So there's different stages in the development of medicines. Phase 2 is proving that something works, and then phase 3 is getting it to the point at which it can then be prescribed to patients through things like the NHS in the UK. So this is an earlier phase study. It's called the CLIMB study. And what you can see here is that patients were treated for 28 days with either the treatment or a placebo. There were 29 people who got the treatment and 11 people who got the placebo. And it was nebulized twice a day. So it's an inhaler. Some of you might have taken hypertonic saline before. And this is a little bit like that in my mind. And all of the patients who were enrolled in the study had to have daily production of cough and sputum with lots of symptoms. So this was the study. 40 patients enrolled, 29 got the medicine, 11 got the placebo. 5 people weren't able to finish the study because they had a chest infection during the study. And this is the side effect profile. And what you can see is that, like with hypertonic saline, the main side effect that people were reporting was cough. So 38% of people reported that the medication made them cough more. That's an interesting one because it's obviously reported as a side effect, but one of the main aims of the treatment is to help people clear things from their chest. And to clear things from your chest, you need to cough. So it may not be a side effect. It may actually be the mechanism of action of the medicine. But there were some other side effects, including tiredness and dryness of the mouth. But this is the main outcome of the study. So what you see on the left-hand side here is the symptoms measured by a questionnaire called the St. George's Respiratory Questionnaire that asks things like, how much are you able to do? How much are you coughing? How do you feel? And the CAAT is also a very short questionnaire that asks things like, how often do you cough? How often do you produce sputum? And anything that's lower is better. And what you can see is that the SGRQ was about 4 points lower. and the CAT questionnaire was about 1.5 points lower. So both of those suggest that the symptoms are getting better in patients who are on this medication for 28 days. And that's also what's shown on the right-hand side here. What's added on the right-hand side is that patients still feel a bit better a month after they've stopped taking the medication, which is good. So this is an encouraging initial study that suggests that and this will move now to a phase 3 study in a much larger number of patients, an inhaled medication that helps to increase the clearance of mucus from the lungs that could improve people's symptoms. So that's a nice step forward. There's other medication trials going on in the UK at the moment about new medications to help with mucus clearance. And the largest one is called the CLEAR trial. And this is just finished, and I'm expecting that we'll get the results in the next couple of months. And it's tested hypertonic saline, that some of you may have been on before, carbamazepine, that some of you may have been on before, or together or separately against nothing, to see whether it can improve symptoms or improve quality of life. So within the next couple of months, hopefully we'll be able to say which one of these works. And access to these medicines can be a bit patchy across the NHS, so if it's proven to be effective, hopefully we'll be able to make these things a little bit more routinely available and widely available, because at the moment they're used a bit, but they lack strong evidence to prove that they work. They're expected to report in the next 3 months. So one of the main problems that people have, whether they've got NTM infection as well or just bronchiectasis without NTM, is infection in the lungs. If you send a sputum sample to your doctor, in about 2/3 of cases, it will come up showing a bacteria. And the two most common bacteria that you might have heard of are called Pseudomonas aeruginosa and Haemophilus influenzae. And I'm showing you data here from our European registry, which collected all of this data from just under 20,000 patients. And those are by far the two most common bugs that people see. A funny thing that one of those sort of interesting facts that we found from the data is that Pseudomonas is much more common in the south of Europe. We don't know why. Maybe it likes the hotter weather, or maybe it's to do with things like antibiotic use, but it's an interesting observation. But infection is really important, and Pseudomonas is very important because it's quite resistant to antibiotics and can be quite difficult to treat with oral antibiotics. So people who are unlucky enough to have Pseudomonas often need IV antibiotics, or a lot more antibiotics than people that don't have Pseudomonas. And so one of the treatments that we use most commonly in the NHS for Pseudomonas is inhaled antibiotics. So this is putting an antibiotic into a nebulizer and inhaling it into the lungs. And some of you will know that's also done for some types of NTM. The most commonly used in the UK is colistin, also used as tobramycin and as aztreonam. You may know amikacin is often used for NTM. And there are advantages to giving antibiotics through a nebulizer, because you can give more antibiotic into the lungs directly without causing side effects. There are potential challenges with it as well. The lungs don't like things being put into them. And so the most common side effect with breathing in an antibiotic are cough and breathlessness or chest tightness. And it can also take a long time for taking and then cleaning the nebulizers. And so my patients will often say that bothers them in terms of the burden of treatment. So we've just finished and just reported the largest ever study of inhaled antibiotics in bronchiectasis. This was called the PROMISE study. And this was a global study, 2 trials. And this is done because regulators in the United States want 2 trials to prove something works. 377 people in PROMISE 1, 287 people in PROMISE 2. Those are the 2 trials. One group got the antibiotics via a nebulizer, and one group got the placebo to see whether the antibiotics make a difference. And this is where it was conducted. It was done all over the world, so taking into account that geographical variation that we see in patients. And these were the results. So we've got on this graph the results of our phase 2 study, the results of Promise 1, and then the results of Promise 2, but we've split the results of Promise 2 into before and after the pandemic, because something funny happened when the pandemic broke out, that it became much harder to follow up patients, and actually the study eventually was stopped because it wasn't possible to finish it, the Promise 2 study, because of the pandemic. If we look at the data outside of the pandemic, you see about a 30% reduction in the risk of having an exacerbation. So anything to the left of this line is less chest infections or less exacerbations. But it didn't work during the pandemic, which is interesting, probably because just collecting the data was very difficult. But also patients said that they had a lot less chest infections during the pandemic in general. So this supports the idea that nebulizing antibiotics does work for some people, definitely doesn't work for everybody, but this was exclusively in people with Pseudomonas, and it does seem as if it works. So these are some encouraging results from an antibiotic perspective. And I've put the percentages on here, between 20 and 30% reduction in the risk of having a chest infection is clinically very important. So that's something that we're going to hopefully see used a little bit more often now that we've got some more evidence. There are some really exciting new treatments coming, and in development is a number of new anti-pseudomonal or antibacterial treatments that are different to the old-fashioned antibiotics. One of them that you might have heard a bit about is phage treatment. And I haven't put a slide in, but the first trial of phage treatment reported its results a couple of weeks ago. And some of the results are quite encouraging. The other type of treatment that's coming that's a little bit different is an antibody treatment. Some of you might know, if you've got asthma, for example, that antibodies are becoming quite a common way of treating chronic diseases, and they're widely used in diseases like asthma. These are injections rather than tablets or nebulizers, and the antibodies are very, very targeted. So they take out one part of the immune system or one particular bug. And so we've just completed a trial of an antibody against Pseudomonas, where we gave patients a monthly injection of an anti-Pseudomonal antibody rather than a nebulizer with antibiotics in it. You can imagine the attraction from a patient point of view. Rather than having to take a nebulizer twice a day, imagine if you could control your infection by just having an injection once a month. And so the results of this will be announced very soon. But I can tell you that they look very encouraging. So that may be another new way in the future that we're able to treat these infections. I'll move on to inflammation, and I trained and did my PhD in immunology. So a big part of my career has been showing that bronchiectasis is an inflammatory disease and that we shouldn't just focus on the infection component. And what we know and what we've shown is that it's these cells called neutrophils that cause a lot of the symptoms that you get in bronchiectasis. This is a picture of one migrating into the lung from the blood. So they circulate in the blood, they migrate into the lungs. Then they do this funny thing where they explode, releasing these webs that are shown here. And that's why mucus is very, very sticky, because it contains these sticky webs of inflammation. And so stopping that inflammation could reduce the risk of chest infections and reduce patients' symptoms. And until recently, we didn't have medicines that could do that. But thanks to a lot of hard work over a number of years with the scientists, we've now got medication that can target this process and these inflammatory pathways. And the new type of treatment is called DPP1, or also known as cathepsin C. So they're inhibitors of DPP1, and you're going to hear that a lot over the next few years when people talk about treatments. The DPP1 inhibitors are the new treatment for bronchiectasis. So the phase 3 trial, so this is the trial just before licensing of a new drug, has just been reported for brensocatib, which is the first of the DPP1 inhibitors. So brensocatib is a once daily tablet. It comes in two doses, 25 milligrams and 10 milligrams, and we compared that against placebo over a year. And this was a worldwide trial, and it's the largest ever trial done in bronchiectasis. It was over 1,700 patients. And because we think exacerbations are very important, the main outcome of the trial was reducing the frequency of exacerbations. But we were also interested to look at symptoms and lung function. As I said, it was a global trial, over 1,700 patients, some children, and 1,680 adults. A huge effort across 390 centers all across the world. And this is the exacerbation result. So it reduced the frequency of exacerbations by about 20%. So that's important. And both of the doses seem to report it by this, seem to reduce exacerbations by about the same amount. So that there was no difference between the two doses in the exacerbation endpoint. What I think is really important is that not just we want to stop patients from having chest infections, we want to stop people from getting worse over time. A lot of my patients ask me when they come for their regular clinic visits, how's my CT scan looking, or how's my lung function? Because I want to know if I'm getting worse or if I need to worry about the future. And blowing into the spirometry machine, the lung function machine, is one way of knowing whether things are getting worse over time. And so our patients did this on a regular basis through the trial. And what you can see here with the gray line is that patients lost about 60 milliliters of lung function over about a year. That's about twice as much as you would expect to lose if you don't have bronchiectasis. So it confirms what we already know, that people with bronchiectasis do get worse over time a bit more rapidly than the general population. But look at the line at the top here. This is the 25 milligram tablet of brensocatib. And after about 16 weeks, that line is essentially flat. So it's stopping patients from getting worse over time. And by the end of the study, there's a big difference between the lung function of the people on the treatment and the people on the placebo. So that's really encouraging. It suggests that taking an anti-inflammatory treatment can stop people from getting worse over time. And it'll be interesting to see if this is sustained once people are on the medicine for 2 years and 3 years and 4 years and 5 years, as they likely will be in the near future. So this is not the only anti-inflammatory treatment that's in development. This is now results of a second trial of a different anti-inflammatory tablet. This is not got a proper name yet. It's called BI 1291583. But this was a trial of 322 patients, and it also showed a reduction in exacerbations of about 30%. And that it seemed to work regardless of the underlying cause of your bronchiectasis, which is important. So both of these studies suggest that anti-inflammatory tablets can reduce exacerbations and slow down the rate of decline in lung function, which is really, really, really important. Brensocatib is likely to become available to patients in the UK. The company have estimated it's 2026. A phase 3 trial of this other drug in the same class, which is the BI 1291583. There's a phase 3 trial that's going to start recruiting in 2025. So there will be an opportunity for patients to get access to these medications, at least through clinical trials, as early as the summer of this year, which is really encouraging, because I know a lot of patients are keen to see if this could be something that could help them. So it's a really exciting time for bronchiectasis, having had nothing really to offer patients apart from inhalers and antibiotics for many, many years. We now have new treatments in development for mucociliary clearance, and I've listed some of the drugs that are in trials at the top here. The DPP1 inhibitors are coming out of the trials now and have been shown to be effective and will be made available on the NHS, I'm quite sure. And then there's other anti-inflammatory drugs that are also in development. And then we've got new antibiotics and non-antibiotic drugs that target bacteria that are also in advanced stages of clinical trials. So it's really exciting. Can you imagine the current treatment for bronchiectasis? You might take an inhaler for your breathing, regular antibiotics when you get an infection, a nebulizer with an antibiotic in it. All of the and despite all of those things, patients have a lot of symptoms and exacerbations. In the future, imagine a scenario where bronchiectasis is managed with a combination of physiotherapy, a daily anti-inflammatory tablet, and maybe an injection once a month. That would be a really significant advance to where we are just now. You can never promise anything when it comes to research. Sometimes things don't work. But the future is very bright because a lot of people are working on this at the moment, giving us a very healthy pipeline. My message is a really positive one, that we've actually got a breakthrough for bronchiectasis. I'm going to have to change the start to all of my talks where I say bronchiectasis is a neglected disease with no licensed treatments, because as of next year, it probably will have a licensed treatment and it's not as neglected a disease anymore. I'm really hopeful about the potential for both the anti-inflammatories and the alternatives to antibiotics. And none of these treatments are a cure, but they are likely to have a big impact on people's quality of life while we search for even more effective therapies that might be a cure for bronchiectasis in future. I always think this is very important when we talk about clinical trials, to say a big thank you to all of the people who voluntarily give up their time to make these things happen. Yeah, I talked about a trial there with 1,680 patients. Every single one of those patients, to me are heroic in that they've given up a year of their time to help their fellow patients and do something important for the future of people with lung disease. So a massive thank you to everybody that gives up their time to do clinical studies. And I'll just also acknowledge my team who have helped to conduct a lot of these studies. This is the best picture I've got of the team, but I always feel sad for Amy because she's screaming in the back of this, and I still have no idea why. But I'm very grateful to them for all of their hard work and support. And as I say, a lot of the studies that I showed here are supported by our colleagues in the pharmaceutical industry. So thanks also to them for supporting these studies, because they could invest in lots of other diseases, and it's great that they chose bronchiectasis to do a lot of these trials. And so with that, I'm very happy to take any questions about the studies or about anything to do with bronchiectasis in general. Thank you.
Would you like to take over, Mark, or can I just say a huge thank you, Prof. Chalmers? That was an amazingly clear session, because I certainly understood every single word of it, and I'm sure the rest of the team did as well. And I expect there are loads of questions. If you have questions for Mark and for Prof. Chalmers, you can put your hand up, or you can use the reaction thing, and we will try and look and see. And I understand that there are already a few questions that have been sent in. Can we just address the questions that have already been sent in first, and then John will come to you. Sandra will come to you.
Yes,
afterwards.
yes.
Thank you. Jacqueline, have you got the questions?
I haven't got them to hand because I sent them to Mark.
Sorry, yeah. Mark, have you got the questions to hand, Mark?
Yes, yeah.
Good.
Firstly, I just want to say, James and I know each other very well, and it is such amazing. James has been responsible for making bronchiectasis and chronic respiratory infection something that was completely ignored by so many in the medical trade, to something that is right at the forefront. So the science that he described, he doesn't say it, but he's driven all of this, or so much of it. And so we owe a huge debt to James. And it is remarkable, the changes, as he said, that he's seeing. I think that one of the and a number of the questions have already been answered by James, because he was asked. There were questions in particular about what drugs to take, and I'm aware, James, that you haven't got very long. So what I will do is I will manage those when you sign off. How long do you think you have in terms of questions?
I'm fine for 15 minutes. I'm absolutely fine if that's okay.
Great. Okay. So one thing that a question that was asked was in terms of bronchiectasis, if we could just focus on that, that question of inflammation, because as you say, you have very much changed, and it's starting to change the view that this is all about infections, and it's now much more about inflammation and about sputum clearance. And a question that was sent in, and I'll just read the question. What do you think about the contentious issue that some foods, such as dairy and ultra-processed foods, cause inflammation, and does this affect the lungs? And hence, should we be actually thinking of modifying diets?
Yeah, so, it's a really good question. As a scientist, the first answer always has to be, I don't have any proof that your diet will change the levels of inflammation in your lungs. On the other hand, there are evidence both in sort of experimental type studies and also in patients that people who eat a healthier diet are more likely to have a healthier outcome in terms of chest infections and in terms of symptoms. So I don't recommend restricted diets or fad diets or these sorts of things, but I recommend to all of my patients that they eat a healthy diet with plenty of fruit and vegetables, and take regular exercise. And it is my observation, and it is just anecdotal, that my patients that look after their general health also seem to have better lung health. And if you want a little link back to my presentation, remember that one of the things that was in that nebulizer that seemed to improve mucus clearance was vitamin C, which is what's in fruit, and that seemed to liquefy the mucus. So I think there probably is a link with diet, and I think eating a healthy diet is important. The other great fact that I always like to remind people of in terms of lifestyle is that the clearance of your mucus is completely dependent on the beating of the cilia in your airways, those little hairs that beat. They speed up when you exercise. So even if you go for a nice walk, your mucus clearance will be enhanced. So it doesn't always have to be about drugs. Yeah, you could take a drug that speeds up your mucus clearance, or you could go for a nice walk.
And that actually comes on to a question that was asked about when to do physiotherapy. And in other words, if people aren't producing sputum and they're encouraged to clear, is it worth doing? And I think Reese is also on the call as well from Cambridge, the lead physio there. But what do you say to your patients, James? Because it is something we hear, isn't it?
It's a great question. So if it's very simple, if you've got feeling of congestion, you've got cough, you've got mucus that you produce, I recommend to my patients that they do at least twice daily airway clearance to try and empty the tank, as it were. And that's best done with the support of a specialist physiotherapist who can personalize the regime for you. The question, I think, is if you feel as if you've not got mucus in the chest, should you also be doing those exercises? That's a little bit more tricky. What I say to my patients is, if you genuinely got nothing in there and you don't feel as if there's anything in there, do try taking regular exercise, because sometimes when you get deep breathing, you mobilize the smaller parts of the lung, and you do find that a little bit comes out. And so exercise might be all that you need to manage your small amount of mucus. But I have some patients who tell me that they don't have much mucus. And when I look on their CAT scans, I see lots and lots of mucus in their chest. And when I give them a medication and I ask them to do airway clearance exercises, the next time they come back to clinic, they go, I didn't realize I had so much stuff in my chest, but I've cleared it all now and I feel a lot better. So even if you don't feel congested, if your doctor recommends to you that you should try to do these exercises, I would recommend that you do them.
Thank you. And I think that's a really important point, that with the availability of more tests such as CT scanning, and I should say, I'm not saying everybody should have CT scans all the time, but I do think it's important that there are standardized assessments done. You can find much more, as you say, sputum plugging, which, as you were saying, is central to a lot of people's symptoms that you may not be aware of yourselves, but if you can clear that sputum. You also made the really important point that sputum that is thick and sticky, in other words, unhydrated, is going to be much harder to clear. And I know that's, again, something that Rhys Hurst will always emphasize in his and other physiotherapists' presentations. So there's things we can do. There's a couple
so just on that, I mean, you'd be amazed how just increasing the amount of water that you drink can make a difference. You know, the hydration of your mucus is a reflection of your hydration status, and most of us, including probably me, don't drink enough water and drink too many things that dehydrate us, and that can make a difference to your mucus clearance just by drinking more water.
And just thinking about that, someone asked the question, do weather conditions affect bronchiectasis? And whilst we might be thinking about humidity, I guess also heat would be important there too.
Yeah, so there is a little bit of evidence around that environmental conditions make a difference. At the personal level, a lot of our patients will say that they get more chest infections during the winter when things are cold. But heat dries out the airways, obviously, and so may lead to more mucus plugging and patients feeling more sticky and more congested. And that's also something that you sometimes hear from patients. And then environmental conditions can make a difference. We've got several studies now that show that air pollution can be a trigger of exacerbations of bronchiectasis. So we do have to be somewhat mindful of our environment for people with lung conditions.
Thank you. And then there were a couple of questions about exacerbations, and it almost feels as if that whole, I mean, exacerbations is quite a broad term, and you very helpfully put a definition, which was great. But do you think that, I mean, one person said, I'm confused about it. Does it mean infection? Does it mean inflammation? What should I regard as an exacerbation? And therefore, when should I be prompted to do things? Do you think the paradigm is going to change, is changing and is going to change in terms of what we call an exacerbation?
Yeah, I think this is really, really tricky. So a lot of my patients ask the same thing. So I'll ask them, you know, have you had any chest infections in the last year? And they'll say no. And then my patients will describe to me several episodes where their symptoms were much worse for a week or 10 days. And I would say, well, that's what I would call an exacerbation. What one patient will call an exacerbation, another patient will not call an exacerbation. And that, I think, is tricky. So part of our job as doctors, when we diagnose bronchiectasis, is to talk to patients about what is an exacerbation, when should you be seeking antibiotics. And so what I say to my patients is that if you've got a worsening of symptoms that's different from your day-to-day for more than a couple of days, so you're coughing more, you're producing more phlegm, the phlegm has changed color, you feel more breathless, you feel more tired, any combination of those symptoms for more than a couple of days, that's an exacerbation. And it's better to treat it early because we've got some data that we will publish shortly that an exacerbation, even if it's treated, lasts for about 20 days on average. The patients feel worse for about 20 days. But the longer it takes to treat it, the longer the duration of symptoms. And so I encourage my patients, if they've got those symptoms sustained for a couple of days, to call the GP or to call me or the healthcare provider and get prompt treatment.
Thank you. And then just going to a question in the chat, I'll just read it out. It's from Cherry. Great news about the future. I'm concerned I often see reference to the side effects of brensocatib and the loss of teeth. Is that something?
What a great question. So that's really important for me to address. And I'm grateful to you for putting that up. That's completely untrue. So there is no effect of brensocatib on teeth. And I'll explain. So there's a very rare genetic condition called Papillon-Lefèvre, which you'll never have heard of, but that's okay. Most doctors have never heard of it. And it's where children lose their teeth early because of a genetic problem. And there's a very tenuous link between that and the medication that we give. And because of that, this rumor has sort of circulated that there will be some issue with teeth. What we did in order to address that in one of our studies was that every patient in the study, 256 patients, had to go to the dentist every 2 months and have their teeth examined while they were on the medicine. And we've published the results of the teeth examinations. There was literally no effect of the drug on the teeth, nothing at all. So there is no evidence from any of the studies that there's an effect of the medicine on teeth. So it's something that we looked for because it was raised as a concern, but it's not there. I will say there is one side effect with brensocatib that has come out of the studies, which is that it causes a little bit of in about 5% of people, about 1 in 20 people, a small skin rash, so thickening of the skin on the hands or on other parts of the body. It doesn't seem to bother people very much, but it is the main side effect that's come out of the studies. So I say that in the interests of full transparency.
Thank you very much. And then just following on from that, a question that I was surprised almost people hadn't asked before, but Donna has now asked it. Which patients will most likely be offered brensocatib when it is first made available?
That's a great question. And obviously I'm not the person who's going to be making that decision. It'll be in the UK, it will be NICE that will make the decision about which patients can have it. Usually when you're trying to guess these things, it's good to look at the people who got it in the clinical trial. And so in that, it was people who had at least 2 chest infections in the previous year, had significant symptoms, and any type of bronchiectasis. So that if you were to go strictly with what was in the trials, those are the people who would be offered it. Historically, with other medicines in other diseases, NICE has been a bit more restrictive in order to manage NHS budgets. And so it's possible that the threshold for exacerbations might be a bit higher, or that there'll be other restrictions placed on it, but we just don't know at this stage.
And a population with NTM without bronchiectasis would be unlikely to be, certainly because they weren't in the study, they wouldn't be a group who would be considered at this time.
That's correct. So if you in the trials, if you were on treatment for NTM at the time of the trial, you couldn't go into the trial for obvious reasons. NTM needed to be treated first. If you had a history of NTM and now your bronchiectasis was your main problem, you could go into the trial. And so the people who are from an NTM perspective, the people who are likely to be offered brensocatib would be people whose NTM has been treated and now they're left with residual bronchiectasis.
And last question, because I know you've got to go, is it brensocatib, in other words, stomach kind, given that it's an anti-inflammatory? And I think that's a really important area to do.
Yeah, that's great. I need to think of a better name for it than an anti-inflammatory, don't I? Because it makes people think of ibuprofen and naproxen and things like that. And it's not, it works in a completely different way. So I don't know if maybe I should call it an immunomodulatory or an anti-neutrophil treatment or something like that, rather than an anti-inflammatory. So yeah, there was no evidence at all that it has a stomach effect. So things like anti-inflammatories like ibuprofen and naproxen have a specific effect on the stomach. These types of medicines don't have any effect on the stomach that we know about.
That's great. I just want to check, Shirley, Tanya, Jacqueline, were there any other specific questions for James, or can I see a hand going up? Yes, Fire away.
Sandra had a question that she put her hand up straight at the beginning.
Great.
Can you hear me? Yeah.
Yes.
Yes.
The question really was, I have NTM and bronchiectasis. The NTM hasn't cleared up after treatment. Would I not then be eligible for this drug?
So if you're no longer on treatment for the NTM, you would,
Yeah.
as in the treatment has been discontinued, you would have been eligible for the trial, and so you wouldn't then be excluded from the indication. So it's if that makes sense. Yeah.
Yes, it does. And the Airleaf trial, which I think you said is coming up, how does one apply for that?
Great question. So so the phase 3 trial should begin in about June. So speak to your doctor. So the next time you have an appointment with your doctor, I encourage everybody, by the way, I'm very passionate about this. Next time you see your doctor, go in and make their day by saying, are there any clinical trials going on that you might be able to give me some information about? Because that is the most wonderful thing for doctors to hear, because it means that we've got the message out that research is important, and patients are behind it. So almost every hospital in the UK that looks after bronchiectasis patients has been invited to take part in the latest trial of these anti-inflammatory drugs. So if you go and ask your doctor, there's a good chance your hospital will be one that's taking part.
Okay, thank you very much. Thank you.
And thank you all so much. I just want to say a big thank you to Shirley and Mark for inviting me to do this, and for all of the amazing work you're doing with NTM Patient Care UK. It's wonderful to see the growth and the success of this organisation. Fantastic work.
And I should just add that, sorry, I was just going to say, I should just add that James was instrumental in setting it up as well. Again, he's not saying that, but he was very involved in the very early days. So James, this is your legacy again. So thank you. Shirley, handing over to you now.
Yeah, thank you, James. That's we know how busy you are, and we really appreciate you giving us this time today. And I'm sure we'll be in touch again. Thank you.
Have a great day. Bye-bye.
Thanks, James.
Bye.
Bye.
It was good.
Great. Well, I mean, so I think there's a few things. I think it was great to get James. He gave a presentation. I don't know what your take on it was, but I thought how he pitched that was amazing. I think that he can take extremely complicated areas and discuss them in a way that very few people can do. And of course, it raises lots of questions. What was very handy was that his talk covered a lot of the questions that you'd kindly sent in advance. And so I hope you feel that I covered most of the things that were directly relevant to his talk. We do have some further questions, but I just thought maybe if this works for you, perhaps we'd get some quick reflections on what he said, and if there was anything that you either wanted me to perhaps explain in a bit more detail, or just what you take away from the talk, because that's I think quite an important part of us as a group. Does anyone want to kick off at all? Sally, I'm seeing a hand going up. You're just on mute, Sally.
Are you talking to me? Because there's two Sallys, aren't you?
Oh,
Sally
you're Sally McCann.
Yes.
Oh, okay.
Hello. Hi. Thanks. Yeah. Just basically, how do you get? So I'm a treated NTM patient, so I'm allegedly clear from NTM. So how would I get to go on the next trial phase?
Yeah. So that's a good point. So as James was saying, people tend to, for the purposes of trials, there's what happens in real life, which is people have a number of different conditions, and they might have NTM and some bronchiectasis, or someone might have COPD and an NTM, or they may have a combination of the both. You know, in trials, people try and find quite defined groups, because then you're testing, say, a drug against in a group of people who you know as much as possible what they all look like. Something like the Airleaf study, so that was what he was mentioning at the end, that would be an exclusion criteria would be if someone were on treatment for NTM at the moment. If they had bronchiectasis, though, then they might be eligible. So that's the entry criteria. Then there is the question of, okay, well, if I'm say seen at a hospital where they don't seem to be doing much research, or they're not necessarily engaged with study, how do I get onto that? And there's a few ways of doing that. One is to actually encourage your local clinicians to look into the study and try and be on board. And I think with the Airleaf study, I think that's what they will have to do, actually. I think that there is one of the reasons, as you know, that we set up both the NTM network and the NTM patient care group, and the network is for the clinical teams, was that it was clear that there were a few groups who knew a lot about NTM and were very switched on. And by NTM, I also include bronchiectasis. And then there was the rest of us who really who didn't have access to things necessarily. And that was why it was so important to start, as he was saying, to spread the word. So going to your clinicians and saying, I've heard about this study, can you look into it? Can I do this study from this hospital? If not, is there a hospital nearby where I could take part in the study? And that, is there a hospital nearby, is the way more and more that we're starting to do that. So to give you another example, we're doing a slightly different area, but really quite a complex study with a few hospitals across the UK, not in NTM, it's in fact in tuberculosis. Because the other hospitals don't have the facilities that we have in my place, those hospitals will speak to their patients and then refer them to us for the study. Now, it means you have to potentially travel a bit, but usually that's managed in a way where we think quite carefully about what it would involve. But you can do those sort of things. And increasingly, that's what we're trying to encourage. In other words, making research more and more available for anybody with a condition. I'd be confident and say in the next 2 or 3 years that will be a reality. At the moment, it needs you, Sally, and others to actually go and pester your doctors and nurses about this.
Okay, well, I've recently been taken on by the I'm under the Brompton, but I also go to the King Edward VII in Windsor for chest, the breathing and things like that.
Yeah.
And they didn't know really anything about NTM, so I got one of the ladies from the group to send a load of posters, which they're absolutely thrilled with.
Hey.
The consultants there is really been looking into NTM. But I did say that I might just say, you have a link to this recording afterwards. Would I be able to send them the link, because they would love to have that link to this discussion?
Over to our technical team.
I would just email them the link, but it's more of a permissions thing, isn't it?
Yeah.
I mean, we could send it to anyone, but I think it's data protection, isn't it? If everyone's agreed. I think the people that don't want to be on the call of like to be seen, then they'll have turned their cameras off. So I think it's fine, but
yeah, it's only going to be seen by the clinical staff that are interested in promoting NTM awareness. So
I'll send it to you specifically as well once I get once I know.
Okay, thank you.
Shall I contact Prof Chalmers and ask him if he minds if you pass it on to your clinical team?
Yes.
I'll get back to you on that, Sally.
Yes.
Would that be okay?
Yes.
I'll get his permission first.
Yeah.
I'm sure he will agree, but
yes. Okay, thank you.
Great. Okay. So we do have any other comments specifically about James's presentation? If not, I will cover some of the questions that came up. And again, as always, it's really great. The questions, as James said, it's fantastic, the questions you ask. And because they're often, several people would have wondered about them, and they often then generate a lot of discussion and so forth. And so do send them in, and you can always send them in not just a few days before the meeting. If you have a question, we can keep them in readiness for the meeting. If something dawns on you, in a week's time, email us and we'll try and hold on to it. So bracketing them together, there were several questions about treatment, and I think they are interesting to reflect on. Again, if we think about what James was presenting, which is that the paradigm about what's going on in the lungs, well, there's mucus, and that seems really important because that causes a lot of symptoms and almost certainly leads to an increased risk of infections, as James was saying. There's the inflammation, which is, of course, strongly linked to the mucus, and itself drives infection and results from infection. And you can see how these things are all very central. And then there's the bugs themselves. And in NTM, although James, remember, was talking about this bug Pseudomonas. Pseudomonas is a pathogen. What I mean by that is it will cause a problem. If it gets into the lung, it can cause damage directly. NTM in general don't. NTM get in and they sit there and they provoke an immune response. And so as a result of them just not being cleared, they cause progressive lung damage. And you can see as we start to think about that, how the shift might start to come from, yes, we want to kill the NTM, but also we want to move them out of the lung. We want to clear the sputum. We want to reduce the inflammation. One of the questions that was asked was, well, and there's also been some questions in the chat about, well, what is this inflammation thing? I mean, because typically people have thought about using steroids to control inflammation. And of course, inhaled steroids are routinely used both for airways conditions such as asthma, COPD, and in some people with bronchiectasis. Yet we know also that if you use a lot of inhaled steroid, there is an increased risk of having NTM in the lung. In other words, the steroids not only reduce the inflammation from high levels to normal, in inverted commas, levels, but actually can reduce the body's ability to fight infection significantly, and therefore people get more NTM. So to give you a concrete example of that, if I see someone who is a new diagnosis of NTM lung disease, one of the first things we will do is go through the medication they're on and determine, are they on drugs which are altering their immunity? And that can include high doses of inhaled steroids. So then what do you do? Because if someone needs inhaled steroids, say for their airways disease, asthma, but we are concerned about the dose, well, we try and reduce the dose. So we get the dose down to a level where their asthma is well controlled. In other words, they're not coughing at night, they're not having tightening of their chest, they're able to function as normal, and measures such as maybe in the blood and maybe in inhaled air, exhaled air are looking okay. And at the same time, we're giving them enough steroid, but not too much, so that you're getting more risk of the NTM remaining in the lungs. So there is a balance, and you can see that starts to move towards personalization of medicine, and I think that's a really important issue. I think each one of you who's either on treatment or thinking about treatment need to be asking yourself and your clinicians, okay, what do I need? What do I want to achieve? What does the evidence tell me? That's why I was mentioning about CT scans earlier. In my place, we like CT scanning. Why? Gives us a lot more information than a chest X-ray. And often it's a very good visual aid as well. If you're looking at a CT scan that is yours and someone says, okay, this is the area that there's a problem. This is the mucus that's sitting in your lungs. So despite, say, the physio or the exercise you've been taking, or it confirms the need for those things. So I'm a big fan of the feedback loop that comes with investigations such as that. Any questions about inflammation that flow from that? I'm just going to scan. I see Lorraine's hand's gone up. Lorraine, fire away. Just take yourself off mute.
Yeah, that's what I'm trying to do.
Lovely.
Sorry. Yeah, so I'm on a steroid inhaler for my asthma on the highest dose that it comes in. So
Yeah.
does that mean I should really go on a lower dose to help the NTM?
Yeah, so I think you should absolutely talk to the people who are involved in your healthcare, so your doctors and your nurses, and say, is this the right dose for me? Could I go lower? Lower normally means what I tend to do is a stepwise reduction. So I wouldn't just stop it, definitely. I'd look at what the inhalers you're on, the dose you're on, and say, okay, let's drop down a bit. And then, of course, that's a measure of how you're doing in terms of the reason the inhaler was started. But reviewing medication, I think, is really, really, really important.
The other thing is, I've asked my consultant about lung clearance.
Yeah.
And she says, no, I don't need it.
Well,
And
that might be right.
I've asked it a few times. I've asked the physio as well, and they just say, no, you don't need it. And I'm confused.
Okay, so two things. It may be that in your specific case, it may be that for some, I don't know why, and we don't obviously need to go into it. It may be that you just have pristine looking airways where you're not producing much sputum, etc., etc., etc. It may be that. The other thing, of course, is that it's great that you've been reviewed by a physio, and I think that's a really important thing. And I was going to actually pull Reese in because I see.
When I say physio, it was being sent to an exercise class because I asked about physio, and they just sent me to an exercise class.
Okay, so
it's
Reese. So those of you who don't know Reese, do you mind introducing yourself and then?
Yeah, of course. Thanks, Mark. Yeah, morning all. Yes, so my name's Reese, and I'm a physiotherapist based at Papworth Hospital in Cambridge. So we sort of see, a large portion of people with NTM for treatment initiation and just sort of monitoring as you go along. Yeah, so Lorraine, like Mark said, that obviously here is, it could be that actually from what they've seen and scans on that side, that actually you don't need direct clearance, but kind of also what Professor Chalmers alluded to as well, that there's still lots of things we can do for good lung health and for sort of lung hygiene, as I call it. And that can come from simple, hydration and diet and looking after yourself to just sort of activity, making sure that we're meeting the, our Department of Health and World Health Organization say that we should be doing 150 minutes of sort of moderate activity a week. And that can be walking, that doesn't have to be going to the gym. So actually meeting those things will help your cilia, will help your clearance. So actually it's really important things that you can still do without it being direct physiotherapy as such. But an exercise class is often they're linked to things called pulmonary rehabilitation. And actually they're very good in, managing people's condition, building up your reserve and building up your resilience. So that can be something that's worth exploring as well.
Yeah, I've done that. I just found it very difficult because both my knees are shot.
Yeah.
I struggle with doing physical, doing the steps exercise is just a no for me. I can't do steps. Just can't bend my knees that much.
Yeah. And that's what's tricky. Everyone's got those sort of personalized differences. So anything you can do that just raises your heart rate a little bit, gets you deep breathing a bit more is really beneficial.
Yeah, I want to try seated yoga or something that's just something to get me moving because I'm not moving enough. I appreciate that. But thank you. I appreciate it.
Yeah, and I think the other thing, Tiffany, will come to you in just one moment. The other thing, you mentioned yoga. I think the other thing, and it was really striking. I was on a call, in fact, Tanya, Jacqueline, Shirley and I were on a call with NTMIR last night. And NTMIR are the equivalent, though much larger, organization to NTM patient care based in the US. And one of the fascinating things they were talking about was the level of psychological support that is available and nutritional support. These are things that, we can only dream of, but you can do things for yourself. And I think something like yoga, something like mindfulness, although it sounds a bit, what's that all mean? I think things like that actually empower you and enable you to, if you like, have a more positive outlook in what can be very difficult times is incredibly important. I can't stress how important it is. Tiffany.
Hi, Mark. Hi, everyone. Thank you for today. It's been incredibly useful. I have a couple of questions, one about inflammation and one about new antibiotics. So the question about inflammation, I have NTM. I've had it for 3 years. I am not on treatment. I've managed to keep it stable with twice a day hypertonic saline and chest physio. And actually, I don't produce much mucus, but I do think that it helps in some way, or at least I feel like I'm doing something. My question is around inhaled steroids. I am under Prof. Lobinger at the Brompton. And at one point when I had an exacerbation, he asked me to start taking Symbicort to just try and help get the inflammation down. And I had this conversation about, I'm worried that this might spike the NTM. And he said, I understand completely, but at the moment, I think the inflammation is doing more damage. And then he said, we can start tapering off, which I have done. My question specifically is, if you have an exacerbation and you maybe take antibiotics, etc., could you introduce just in short term something like Symbicort just to help bring all that inflammation down and then take it out again? Is that an option, so you're not on it all the time, but you're kind of limiting the damage that the inflammation might be doing?
Yes, a great question, Tiffany. So just for people who don't know what Symbicort is an inhaled drug that's a combination of steroid and also a long-acting bronchodilator. And that means it opens up the airways. And that opening up the airways bit is as important, if you like, as the anti-inflammatory effects of the steroid, because it means with more open airways, you can then clear. Again, hydration, really, really key. So in other words, that you want to move the mucus. So you're reducing the inflammation with the inhaled steroid. You're opening up the airway with the bronchodilator. People feel a bit better and they can clear their mucus. So yeah, the other attractive thing about Symbicort and brackets, other inhaled combination therapies are available, is it was the first one that was used in a way where people could literally go up and down on it. So yes, you can use it for short periods of time. One thing to be aware of with these drugs is that they take a while to have an effect. What do I mean by a while? It takes a few days for them to be effective, so you need to stick with it. Anna had a comment in the chat, which was, well, brensocatib may not affect my teeth, but inhaled steroids definitely do. And remember, steroids will damage gums. They can give you a hoarse voice. So if you're using inhaled steroids, you take a glass of clean water, rinse your mouth and spit out afterwards. Try and minimize the deposition in your mouth to get more into your lungs. Does that answer it?
Yes, it really does. Thank you. I guess one of the side effects, and I think it's the bronchodilator aspect of it, was that I was clearing more mucus. And that maybe was because I had the more inflammation, but actually a small part of me was like, oh, maybe, this is actually helping more generally. But view to taper it. The second question was earlier it was mentioned that there were new antibiotics coming for NTM, and I know we were talking about bronchiectasis specifically, but that comment was made. Can you give us a bit more information about that?
Yeah, so the main so there's a variety of antibiotics, and in fact, what I will probably cover this in a bit more detail later in the year. I'll do a tour. Later in the year is like 3 months or something. Okay. But in general, people are looking again. So just as bronchiectasis was neglected, so NTM was neglected. NTM tended to be, so the bugs themselves tended to be, well, okay, what's been produced in tuberculosis, and then what can we look across and apply to NTM? Now people are developing antibiotics specifically for NTM, and that makes a big difference. There, of course, NTM are, there's around 200 varieties of non-tuberculous mycobacteria. So to expect a single drug to be effective for all of them might be unrealistic. However, the common ones, so for pulmonary disease, that's generally MAC, so that includes intracellular and chimera, abscessus, Kansasii, Zenopi. Those would probably be the top ones, I would say. Those will be, we can usually focus antibiotics which will treat and cover most of those. The ones that are, some of them have been, were in phase 1 and phase 2 trials and have now stopped production. And that was usually because they discover one of two things when they start putting it into more humans. Number one, it's not effective. Number two, there's side effects that are a problem. And that was the case for one drug called epetraborole, which has been, they've stopped taking it forward. One thing that people are also doing is thinking about the ways of taking it. In other words, taking it inhaled rather than either intravenously or orally to try and reduce the side effects. And as you know, with amikacin, people are now also changing the formulation. So they're going from using intravenous amikacin to inhaled amikacin, which was just the intravenous formulation, now to liposomal amikacin inhaled, which is a different formulation, that's arikase, of the drug, which you breathe in, which should deliver more of the drug to the lung with less side effects. And so things are evolving all the time. How much access do we have to those? Very little, is the bottom line. We're repurposing drugs. That's slightly different. That's where we have drugs that are used in other areas, which we're now using more of. So Charlie Howarth and myself and Matt Bax, who's based in Wales, we're in a conversation, in fact, last night and this morning about managing a specific person where we were using combinations of drugs that are available, but putting them together in a way that's quite novel. Those sort of things very much a don't try this at home. Those are people who are thinking carefully in a difficult situation, and the person who's going to take it accepting that there's a risk with it. But it is genuinely true. Things are infinitely brighter than they were 2 years ago, an order of magnitude compared to 5. And, you know, we're knocking it out the park in relation to 10 years ago. So it's great. Sue and Sandra, I know Sue, Shirley reminded me, Sue, you had your hand up.
New Zealand, Sue.
Yeah, about inflammation. So the inflammation that's in your lungs, is it the same inflammation that's like throughout your body? So I've just been told I've got, is it oral lichen planus or something? And the dental consultant said he thought it was because of the amount of drugs I was on, but he said it's also an inflammatory condition.
Yeah.
So does that mean my body is just an inflammatory body, or are they different inflammations, or?
Yes.
Yeah,
Well, it is, you know, it's so sorry, Sue, I was talking across you. That goes absolutely to the heart of what is happening in NTM. Because if we look on this call, how many guys are there and how many women are there? Yeah, absolutely. You don't need to count. It's pretty obvious. So NTM, by and large, NTM pulmonary disease affects women more than men. And what is that about? Well, that's something to do with how bugs are handled, or inflammation is handled by women over men. And to make a really broad distinction, and apologies if you've heard me say this before, during COVID, lots of men died and women didn't. Long COVID, more women got long COVID and less men did. So what's that about? That is about how we react to things. If I encounter a bug, I don't have a very good anti-infection. As a male, my ability to handle infection isn't very good. Women are much better at it, which is why they survived COVID. But women have a more inflammatory state than men. And that's why there's probably more long COVID and probably more MAC, I think, or more NTM. That's really basic what I'm saying, but that is probably what it is. So it's a variety of different things, which means why, because that's a question I'm asked all the time. A husband and wife, and the husband will say, why has my partner got NTM and I haven't? We have exactly the same exposures, we do all the same things, we both, you know. And so I think it's that. So the lichen planus may or may not be related, but it's definitely true that people have, for whatever reason, a predisposition to things. But you know, as a male, I would say women in general have better health. I'm sorry about the NTM, but other things you avoid. Cardiovascular disease, you just don't have the same problems. And as I say, your ability to handle infections, you can get away with without antibiotics in a way that I probably can't.
Interesting. Thank you.
I'm just looking. So Sandra, I think you had a question too,
Yes.
and then
Okay.
yes,
Yep.
please go ahead.
Hello. Just a quick question, really. I've got NTM and bronchiectasis, and I've been on a trial for NTM and had Arikayce, inhaled Arikayce, and a couple of antibiotics, but it unfortunately hasn't cleared up. Does that mean it's still doing damage? I mean, I do everything else that you've talked about, you know, exercise, diet, clearance every day, that sort of thing, but it just leaves you slightly uneasy, thinking, is it eating away or is it just laying there?
Yeah, that's
I'm
such a
sure other people, yeah.
That's a really good question, and there was a question actually which was in the questions that were sent in, which is like, so now what happens? So in other words, you know, if someone has cleared NTM, or if they haven't cleared the NTM, then what happens?
Yeah.
Okay, so there's a few things. Certainly, it's nice to see success, isn't it? So it's nice if one has NTM to say, okay, I've cleared it. But then there's the issue about, well, okay, if I'm being told it's in the environment, is it going to come back? And what can I do to manage that? And we'll talk about that in a moment. But let's just think about the situations where we're saying, well, okay, I think I've cleared the NTM, but I'm not quite sure, and I intermittently isolate NTM. So what's the NTM, what's it doing there? Well, we know a few things. We know, as Reese was saying, that if you do regular sputum clearance, you're shifting the bugs out. So you're not letting them get a foothold. So that's really important. Thinking about diet and all of those things, and exercise and healthy mental state and so forth, that's all great. But then what do we do? Because if I'm do I carry on, say, if I were on treatment, when might I need to restart them? What about the inhaled steroids thing? And I think you then move to a situation where you are really having to personalize your own care. And what I mean by that is some people, for example, may need intermittent bursts of treatment. They may need quite focused treatment during an exacerbation, or they may need to be monitored. And if the sputum starts to suggest that the bugs are coming back, then they may need a course of treatment. Other people may remain completely well, but still have that thing about, okay, what do I do? How do I get monitored? In terms of assessing what you can do, I think starting from the best possible baseline you can. So Lorraine was saying about how difficult it is to do exercise if your knees are playing up, and that's absolutely right. And I thought Reese's comment was really important, which is, well, yes, this is what we see in real life, isn't it? That we will try and offer you a suite of things to do. And some of them might be very possible, and some of them might be near impossible, because if they require, say, a lot of physical exercise that is quite weight bearing and the knees don't work so well, then that's going to be harder to do. I think one of the other issues with NTM, and I don't really know how to manage this, and I might just call Jenny Keane, I know was on the call earlier, is that question about how do you manage the slightly frightening chronicity of NTM? You know, so give you an example. I treat people with tuberculosis, and at the end of 6, 9, 12, or sometimes 18 months, I can usually say, we're done, you're cured. That's not the same here. And that's a very different paradigm. And I appreciate that. And that's difficult. And so, again, one of the things, obviously, about NTM patient care for me was setting up a group such as this. Jenny.
Thanks, Mark. Yeah, I agree with you. You know, with TB, it's fully curable if they take the meds, and it's, 6 to 9 months, sometimes a year. With NTM, we're looking at 2 years, perhaps plus for some patients. And I think sometimes, helping the patient even starting on that journey can be really hard. And I mean, this support group is fantastic. I mean, in the past, I've budded patients up before NTM patient care even began, which was really valuable. I've currently got a gentleman, and we wanted to start him on treatment 6 weeks ago, and he's just not coming to clinic. I spent 45 minutes on the phone with him last week, and he just thinks, what's the point? What's the point of me starting on this journey with medication that's going to make me feel awful? It's, I'm a burden to the NHS. There isn't any point. And I was trying to encourage him. I've posted him your leaflets. I've tried to encourage him to join the group. I don't know if he has reached out. And it's, you know, it's sort of, what more can I do as a healthcare professional to just engage this person, really? Because, you know, just encouraging him to start the journey on his NTM treatment in the hope that he might see some gain quality of life, really, that will, you know, make him take that journey further forward.
I had treatment for 12 months. I mean, is 12 months sufficient to really get rid of it, or should I ask to go back on it? You know, I'm not sure. It's just knowing you've still got it and really knowing whether you should be taking action or whether you should just be managing it. You know, you can tell you've got it by, well, A, the way you feel and this horrible yellow, almost greeny yellow phlegm, and then that clears and you get the bronchiectasis phlegm, which is quite clear, quite, you know, white and clear. It's like two distinct things. Yeah.
So I think what's worth it, and again in general terms, is going back to your healthcare provider and providing sputum samples and saying what are we growing in this. So if you can get that done, I think, and that's a general thing as well. I think it's really important that people have consistent, systematic monitoring. I mean, the people that we see in clinic here, they're driven, well, in fact, they're not driven mad. I love the idea that they now bring in regularly sputum pots. They go, here's the present for you, Mark. And so sputum comes in on a regular basis. That is fantastic. As far as I'm concerned, that's fantastic, because that gives us a handle about what's happening. And I think that is important, because that can determine decisions. And of course, just because one's isolating NTM in sputum doesn't mean necessarily more specific treatment. It may be, as we were saying, looking at everything else, thinking about some lifestyle changes, thinking about increasing sputum clearance, thinking about, there's a question about how frequently should CT scans be done. I would say, I think everybody who's diagnosed with NTM pulmonary disease should have a CT scan once, and then can make a decision on further CT scanning as required. But I think getting the anatomy is really important. So I'd say that. So Nick, you had your hand up. Is that right, or did I miss that? And then to Sandra.
Yeah, thank you, Mark. Yes, a couple I cycle with have had a chronic cough for 2 or 3 years, and it's quite a difficult form at times, and repeated bouts of respiratory infection. They'd be very interested to see Professor Chalmers' contribution on bronchiectasis, because one of them has actually had that confirmed in the lungs. Is that all right?
Yeah.
If I'm clever enough to organise the recording.
Yeah, we can. Well, Tanya will again, our technical support team. If that's okay, Tanya. Yeah, Tanya says yes.
Thanks very much. Thank you.
Great. Sandra.
Yeah, hi. Thank you for this chance of, let me ask you something. And it came on my mind, this fact that you mentioned, the fact that the female are slightly different from, males in terms of reactions, and this inflammation, general inflammation, could be related with long COVID, which women, tend to have more than men, as you said. I mean, so I was thinking about the fact that when you have menopause, the women have menopause, they may lose some types of hormones. And so I was wondering about the what they commonly use to treat women when they have the menopause, the hormone replacement therapy. So beside the fact that the hormone replacement therapy could expose to higher risks to breast cancers and whatsoever, but could that therapy also be somehow related with some help for inflammation that many people experience? I mean, women still thinking about the gender, So has any kind of research done in terms of hormones therapies to help the inflammation somehow? Because we know body, everything is related. So sometimes you study the lungs, but then you have to go to look for somewhere else. So I hope I have
Yeah,
posted
no,
the question in a clear
yeah, no,
statement.
it's really clear, and certainly the way of, in some ways, a test of that would be, okay, people who are not, so younger women who are not perimenopausal or postmenopausal, what happens there? And of course, that gets because do they have less NTM and less bronchiectasis? To which the answer is, in general terms, yes, but of course, conditions like NTM and bronchiectasis seem to happen at a later age anyway, in both men and women. If you were to talk to people who are keen advocates of hormone replacement therapy, they would say it will definitely help. The evidence, as far as I'm aware, is less strong though, and so I don't know. But there is definitely something in this. We do not know what it is, and I think it's probably more subtle than just menopause. I think there's probably something innate about people's responses, but that may well be within that some element that you actually need to have a slightly different endocrine or hormonal profile, which may be what drives it. But I'm unaware, and that's because I haven't looked for it, the evidence of saying it's specific to a hormonal state itself. But you're right, these things are really important, and we need to.
Are there any studies, as far as you know, on that? Ongoing studies, ongoing?
I'm not sure. I can look for you. I don't know.
Okay, thank you.
Okay, just going to check now. We are 11:29, which is, so you've put up with an hour and a half of being talked at. And so I'm going to draw it to a close unless there's absolutely any burning issues. Anybody? Any hands?
Mark,
In which case, yes.
Mark,
Graham, great to see you.
No,
Yes,
great to see you.
Hi.
Mark, could I just ask you a question in relation to sputum collection and testing for AAFB? As you know, I see my consultant in York every 3 months, and then I see Professor D'Souza at Newcastle every 6 months. And they do a routine sputum sample for AAFB every 3 months. And I noted on the report from this month's 3-month AAFB report, which came back, of course, AAFB positive, liquid culture positive, solid culture positive, awaiting identification.
Yeah.
And then Public Health England had written, stop sending so many sputum samples AAFB because you're doing them every 3 months. Is that too much?
I don't think so. No, I don't think so. Look, Jenny's head is shaking as well. I think we're if we can get them, we're delighted. I mean, no, it's terrible, isn't it? Fessing up to the fact you like people to bring sputum to you, but it's, if we can get them, that's fantastic. Our biggest concern is when we're not getting a handle on it. You know, I recently have been involved in managing someone who refused to provide any samples whatsoever, and that was extremely difficult. Extremely difficult. We could not gauge how things were going, and you know, if you haven't got sputum, then you're, yes, of course, symptoms, that's helpful, but as we were saying, as Sandra was saying, you know, you're not quite, you haven't got the whole picture. We can't do regular imaging. You know, we couldn't do CT scans every 3 months. We shouldn't do them any more frequently than once yearly, and even then you don't want to do it that frequently, as you know, going forward into the future. So I think sputum, I think if you're seeing repeatedly negative samples, then I think you can do it less frequently.
Mine keep returning positive, Mark.
So, and I think then in particular, when you're then thinking about shifting treatments, maybe, then I think that's another really important time to be getting regular. So I'm sort of surprised. They obviously were having a bad day in the public health labs.
Okay. So just disregard the comments on the report for public health.
Yeah, let Tony and let your consultants in York, Tony D'Souza, they'll fight your corner for you.
Yeah, okay. Thank you, Mark.
He'll manage all of that.
Yeah, thank you, Mark.
Well, I'm going to hand over to Tanya and Shirley now, but just say, as always, it is so inspiring. I can't tell you how important this is. It's amazing, and you could tell James was was loving it too. It's also, by the way, great to see John on the call. John, where are you in the world? Dare I ask? You just.
Sorry.
Hi folks, I am in the Dominican Republic, which I feel a little bit loath to mention because I know the weather's terrible in England, but lovely to see you all, and well worth getting up early to see James's presentation, which I thought was excellent, and lovely to see lots of faces that I've spoken to over the years. So
Yeah, very much. Great to see you too, John.
John,
Shirley,
have you got a
Tanya,
couple of minutes to stay on?
yeah, no
John,
problem.
do you have a couple of minutes to stay on? We'll say goodbye to the rest of you. Thank you so much, and thanks for your questions. Keep them coming. We will be sending out emails about what we're planning to do and how you can be more involved if you would like to be. We're not pushing anyone, but if you would like to be more involved, watch this space, and we'll be in touch soon. Bye, everyone. Tanya, don't switch off.
Thank you. Bye. Thank you.
Bye. Thank you.
Thank you.
Thank you. Bye bye.